Hello and welcome back. In this episode, we discuss respiratory support and management options for respiratory failure. Remember, the other setting in which respiratory support is discussed is the process of resuscitation in emergencies, beginning with A, B, and C, including airway and breathing. Airway includes assessment of airflow and the need for active interventions, while breathing mainly focuses on indices of oxygenation and ventilation. For example, by measuring SpO2 and respiratory rate. What is the first step in the management of respiratory failure then? Please follow this hierarchy. First, emergency assessment and a need for resuscitation through ABC steps. This specifically includes assessment of the need for endotracheal intubation. Next step is to figure out the exact intervention indications. I will discuss it in terms of hierarchies or ladder of indications and contraindications. This needs to be performed in parallel to assessment of the type of respiratory failure, including hypoxic versus hypercapnic or mixed, as we discussed in the previous episode. And finally, address the underlying etiology. Now, what do I exactly mean by the hierarchies or the ladder of respiratory support? When it's determined that the patient, based on initial or next step assessments, requires some degree of respiratory support, the first question to be answered is whether or not the patient needs or meets the indications for active interventions, or the patient needs oxygen supplementation plus watchful close follow-up. I cannot emphasize enough on the fact that we need to distinguish different types of methods for supplemental oxygenation versus active interventions, and no indications for each one of them. Also, I want us to be very careful that indications for active intervention don't mean indications for intubation. And furthermore, I want us to understand that there are other means of active intervention than intubation. And finally, I want us to be mindful that intubation could be endotracheal or nasotracheal. It should also be understood that intubation could be performed in an emergent fashion or crash intubation versus rapid sequence intubation or elective intubations. The other ones, the ones that are not crash intubation, allow some pre-oxygenation and more time. So if we are clear on this, let's go to review different means of respiratory support in this ladder that I have developed here. Please remember, our approach begins with assessment of the need for active intervention. So that will be the bulk of our discussion. But if our initial assessment shows no need for active intervention, we would initiate with O2 supplementation methods. The most common example is a patient with some degree of labored breathing but is capable of maintaining the patency of his or her airways. So if the patient does not have indication for any active intervention for respiratory support, for example, a patient who is able to protect his or her own airway, what are the different means of oxygen supplementation? With order of increasing delivery of oxygen, we have nasal cannula. Please remember, when you hear the word nasal cannula, it means low flow nasal cannula. For higher oxygen provision, we use simple face masks, the so-called ambu-bag or bag valve mask. For even higher oxygen delivery, we attach an oxygen reservoir bag to this ambu-bag and we call it non-rebreather mask. And for the highest oxygen delivery, we use high-flow nasal cannula. But still remember, the main question is whether or not the patient has any indication for active interventions. So let's turn our attention to that. First thing is to please remember, the indications of active intervention is not the same as indications for intubation. Why is it so? Because active intervention could be delivered through either invasive or non-invasive means, and dependent on the precise indications for invasive methods, we usually begin with the non-invasive methods. However, don't confuse the non-invasive means of active intervention from the 4 previously discussed methods of simple oxygen supplementation, such as bag valve mask. That said, what are the clear indications for active intervention? First and foremost, which is the subject of this episode, is respiratory failure. Second indication is airway protection. Third indication is anticipated clinical worsening and deterioration of the patient. And fourth indication is when we need to facilitate some studies or transport of the patient. Important case, you have a patient with some labored breathing. How you know if your patient is capable of protecting the patency of his or her own airway? If the patient has noisy breathing, that indicates risk of airway collapse. Among all the noises, please remember these two: stridor, and the second is a gargling sound during respiration. This is neither a wheeze nor a rhonchi nor a stridor. It's just an indication that there are so much buildup of the secretions due to impaired air protective mechanisms. The second assessment is to see if the patient has proper gag reflex or if the patient is capable of coughing. So you can either test the gag reflex or you can ask the patient to cough. Another means to detect this is to see if the patient is tolerant of oral airway adjuncts such as oropharyngeal airways. That means the patient's gag and cough reflex are muted. But perhaps the most important one is to see if the patient has a degree of altered mental status that indicates no ability to protect the airway, and that is by performing a Glasgow Coma scale. Always remember, if it is 8, intubate. That means if GCS is 8 or less than 8, you need to intubate the patient. Otherwise, more superficial means of altered mental status may require just close monitoring. This and the next subject, anticipated clinical deterioration, brings us to an important discussion, and that is the indications for close monitoring prior to invasive methods of active intervention. In what patients close monitoring and assessment of the need for elective endotracheal intubation is the rule. So we have provided our patient with some form of oxygen supplementation or active intervention that is not invasive yet, and we are going to discuss them, the modes of non-invasive ventilation. But in certain patients, we need to be on alert and perform highly frequent monitoring, the close monitoring, to see if they are deteriorating so that we prepare the intubation team. These are the following: patient who has the risk of worsening or impending obstruction, including anaphylaxis and angioedema patients, burn patients with smoke inhalation, and the third category are the neck trauma patients with possibility of expanding hematoma. Please remember these three categories of possible airway obstruction for close monitoring. Next category needing close monitoring are the patients with epiglottitis. And final category are the ones with deteriorating mental status. The patient has some altered mental status when arrives at the hospital, but it's not yet GCS of 8, but you can see the patient is deteriorating mentally. This patient needs very close monitoring, as at any moment he may crash. However, the other possibility is also there, and he may very well respond to our non-invasive means of ventilation. So, put it simple, the need for airway protection, altered mental status, and respiratory failure are the three major indications for active intervention for respiratory support. Now, among these patients who have the indication for active intervention, some of them have the indication for intubation, and some of them could be managed by non-invasive ventilation. That's the non-invasive mode of active intervention. Now, what is the exact difference between invasive and non-invasive methods? The main difference is the invasive methods bypass the upper airway. So just remember, the active intervention requires delivery through mechanical ventilation, through the ventilator machine. Now, this could be delivered non-invasively using our non-invasive mask and nasal cannula, or it could be delivered through invasive methods such as intubation and surgical airway, the difference being bypassing the upper airway. Now, you may ask then, what's the difference between use of mask or nasal cannula in active intervention versus simple oxygen supplementation? Well, in simple oxygen supplementation, we just connect the patient to an oxygen pump and not to the ventilator. Okay, next question, perhaps one of the very most important questions of this entire episode, are the indications for endotracheal intubation. What are they? First and foremost, an unstable patient who is in shock or in cardiac or respiratory arrest. Second, a patient who has inadequate respiratory effort or the one who is not capable of protecting his airways. What are the examples of this patient? Patient with altered mental status with GCS reaching a value of 8 or less than 8, or a patient with noisy breathing due to worsening airway obstruction or inability to create secretions. Third is a patient with fatiguing respiratory distress. How do we distinguish if a patient's respiratory distress is fatiguing? The most famous example is an asthma patient who is developing CO2 retention as evidenced by respiratory acidosis in ABG. That's just simply comparing the recent and baseline ABG values. But most importantly, remember, if CO2 retention is very severe, that's a PaCO2 greater than 80, this patient needs intubation. Next category of patients requiring intubation are the ones who don't respond to non-invasive ventilation. How do we know if our patient under non-invasive ventilation is non-responder? If his SaO2 fails to reach values more than 90%, or if his PaCO2 does not drop. Is there any other index we can use? Yes, pH is an important index. If a patient has acidosis with pH less than 7.25, which fails to improve at least 0.06 units under non-invasive ventilation, this patient is also demonstrating CO2 retention and respiratory fatigue and requires intubation. Put it simple, failed non-invasive ventilation. Another example is a patient who has contraindication for non-invasive ventilations. That's there is some anatomic abnormalities or other contraindications that make non-invasive ventilation the wrong choice. And finally, remember a failed trial of extubation. Now, this is a tricky situation and we will discuss it in a separate episode. Remember, in the extubation, we usually provide a patient with some means of non-invasive ventilation, and then from that non-invasive type, we completely wean the patient. So this last one just simply means patient remains on invasive modality. So now, true or false? A patient with respiratory distress has altered mental status. Next step is intubation. That's false. We don't know if his altered mental status has reached a GCS of 8 or less than 8. So we need to either evaluate other indices or just begin with some means of non-invasive ventilation. Next very important case. Next case, you are the intern on clinical care unit and you receive a phone call overnight about a septic patient who has labored breathing. The nurse also tells you that his SpO2 is dropping. You calculate the P to F ratio and the value is 180. True or false? Next step in the management is increasing FiO2 for patient through high flow nasal cannula. That is false. Always remember patients with ARDS, as is our case with the most common underlying etiology, which is sepsis, and the PF ratio less than 300, require intubation. The only exception for non-invasive ventilation in patients with ARDS is if they are stable with normal O2 sat. Now, in our mechanical ventilation episode, we will discuss the needed settings in a very prioritized and summary manner. But next question in our patient is, what's the most important factor in the ventilator setting after intubation? First of all, we need the oxygenation index improvement, so we provide FiO2 and PEEP. But the specific consideration for ARDS is low tidal volume, which is usually 6 milliliter per kg. And yes, we need to know this. Now, I mentioned earlier on that intubation could be done emergently, referred to as crash intubation, versus rapid sequence versus electively. Now, what are the two most important indications for crash intubation? If the patient has no airway on the initial survey in emergency department, or if the patient is apneic or pulseless. One little hint here is important from the famous saying of Dr. Conrad Fisher that may sound simplistic, but it's truth, and he always used to say, dead things don't breathe, and he mentions that in the episode related to acute cardiac life support. And by that, he actually drawing our attention to a very important principle, and that's the fact that if pulselessness is due to a type of arrhythmia that's given the evidence, for example, from ECG or patient history, it is wiser to first attempt pharmacologic or electrical cardioversion while continuing our bagging and chest compression based on ACLS protocol, especially because the basis of impaired breathing could be attributed to pulselessness and arrhythmia. This way, we would avoid an extremely invasive procedure like intubation. Please review your ACLS algorithm for this very specific scenario. Now, crash intubation simply means the patient needs intubation within seconds, and it is performed without any pre-oxygenation and is performed without induction agents or neuromuscular blocking paralytics. By the way, can I give an example of the induction agents for ETI? Ketamine or etomidate are well-known examples. How about the paralytic agents? Rocuronium or succinylcholine. Now, is crash intubation the same as rapid sequence intubation? No. Rapid sequence intubation or urgent intubation is when the intubation is needed within minutes. It allows for not only pre-oxygenation, but also for induction and use of paralytics. Remember, the paralytics and induction agents I mentioned usually exert their effects within a minute. And finally, we have the scenario of elective intubation, and that's the patients with the scenarios that I already mentioned who needed close follow-up under non-invasive ventilation methods. However, they are deteriorating. So we initiate pre-oxygenation, we explain the procedure to them, and we go with our induction and paralytic agents. This provides us timely preparation for intubation. Now, please remember, there are other types of invasive interventions, including surgical intervention. One is cricothyrotomy that could be performed by needle or surgical approach, but is an emergency procedure regardless. And the final method, which if everything else fails or if a patient needs long-term active airway, we use tracheostomy, which is an OR ENT procedure. Now that we are clear on the indications for intubation, we can finally turn our attention to protocols of non-invasive ventilation. Still, we are discussing the active intervention, so the patient would be connected to ventilator, not just an oxygen pump, but we do not intubate patient or perform surgical airways. First question, what are the protocols of non-invasive ventilation? The most commonly used protocol are the protocols for positive pressure ventilation, including bilevel positive airway pressure versus continuous positive airway pressure, the BiPAP versus CPAP. The less commonly used protocol is pressure support ventilation. Now, these are some of the technical terms related to ventilator setting. We are not going to discuss them here, but we need to know some very basics for the choice of the protocol. Most important factors to know are indications and contraindications to non-invasive ventilation. What are the contraindications? Well, all the indications for invasive intervention. That's the indications of intubation that we discussed. The patient is not able to protect the airway, patient is at shock or unstable, GCS is less than 8, etc. Don't forget ARDS, please. Now, you may be asked, who are the best candidates for non-invasive positive pressure ventilation? Remember, NIPPV is the best initial mode of treatment for hypercapnic respiratory failure. Other examples include COPD. Well, we discussed that it's usually associated with CO2 retention or hypercapnia. And also, please don't forget cardiogenic pulmonary edema. What are the other indications for positive airway pressure and non-invasive ventilation? We can set the ventilator so that our PPV methods could also improve oxygenation, so we can use them in hypoxic respiratory failure as well. Also, we can use them in patients with increased work of breathing, as seen in restrictive lung disease. And please remember, we use it before or after intubation. You remember we mentioned the pre-oxygenation as a preparation for intubation, and we use these methods of positive airway pressure for that. Also, during extubation, we commonly use BiPAP methods to wean the patients during the trial of extubation. Case: a patient with BMI greater than 30 complains of excessive daytime sleepiness. ABG shows daytime hypercapnia. What is the diagnosis and treatment? This patient has obesity hypoventilation syndrome. Why this is not obstructive sleep apnea, even though he has the risk factor and excessive daytime sleepiness? It's because the patient has daytime hypercapnia. Daytime hypercapnia is not seen in OSA. What's the treatment? Well, this is the treatment for hypercapnia, so we use positive airway pressure. Now, what is the most commonly used or preferred mode of positive airway pressure delivery for hypercapnia? It's bilevel PAP, that's BiPAP, and the reason for it is BiPAP provides the ability to optimally titrate for tidal volume. Why is it so? Well, the term BiPAP, and we will discuss this in mechanical ventilation, but BiPAP means creation of a pressure gradient that exists between inspiratory and expiratory positive airway pressures. Remember, the tidal volume titration is the function of this pressure gradient, and because tidal volume is one of our two most important indices of ventilation in addition to respiratory rate, and ventilation is the target of hypercapnic failure, BiPAP provides the ideal means of treatment for any condition associated with hypercapnia. Now, the other mode of positive airway pressure, that's the other mode of NIPPV, is CPAP, the continuous positive airway pressure. Just remember this, because we have continuous pressure, we have positive and expiratory pressure that will prevent alveolar collapse, and therefore CPAP is ideal for hypoxic respiratory failure. Now, if you are asked what mode of ventilator setting is usually coupled with CPAP, that is pressure support mode, the PSV. Can CPAP optimize tidal volume? No. There is no pressure gradient between inspiratory or expiratory positive airway pressures. That is, we do not have bilevel pressure, and therefore it's not optimized for tidal volume titration. In other words, it's not the optimized mode for hypercapnic failure. Okay, finally, let's address some cases and scenarios in respiratory failure. The patient has come with respiratory distress. You have ordered the initial tests, and based on our episode on differential diagnosis, you have figured out what of the type or types of respiratory failure we are dealing with. By the way, what are the very first steps in all such cases? In addition to pulse oximetry, we need to order ABG to have a clear idea of PaO2. And if we have low PaO2, the very next step would be assessment of AA gradient. We need to order CBC also to rule out the cause of dyspnea is not anemia. Now, what is the mainstay of the management for hypoxic respiratory failure? Improving oxygenation index based on the indications for either supplemental oxygen or active interventions, plus addressing the underlying etiology. What type of hypoxic respiratory failure could also show hypercapnia? That's what are the conditions you expect mixed hypoxic hypercapnic respiratory failure? Conditions associated with hypoventilation. What are the typical scenarios? You have a patient with signs or symptoms or history of hypothyroidism. If this patient comes with altered mental status or cold extremities or any lab finding indicating hypoxemia or hypercapnia, you think of mixed edema, coma. Another important scenario is conditions associated with neuromuscular junction disorders such as Guillain-Barré syndrome. And then we have acute exacerbation of COPD that could be mixed failure. But a challenging scenario could be patients with restrictive lung disease. I want us to remember that we cannot easily categorize the patients with restrictive lung disease to hypoxemic or hypercapnic failure. However, if you are to pick one choice to choose between hypoxic versus hypercapnic, please remember this. The extrinsic restrictive lung diseases, the ones associated with impaired chest wall mechanics, neuromuscular junction disease, obesity, sedative, hypnotic overdose, are the conditions usually associated with impaired ventilation. For example, obesity or kyphoscoliosis reduce the tidal volume, while sedative hypnotics could suppress the respiratory center and lower the respiratory rate, the indices of ventilation. And therefore, in these conditions, the extrinsic type restrictive lung disease, we are mainly dealing with hypercapnic failure. On the other side, let's analyze the intrinsic lung diseases, such as emphysema or idiopathic pulmonary fibrosis or ARDS. These are the conditions that one or more indices of fixed formula of gas diffusion are impaired. For example, in emphysema, surface area is impaired. In ARDS or lung fibrosis, the thickness is increased, and therefore the gas exchange for oxygenation is impaired, and these conditions are mainly associated with hypoxic type or hypoxemic type respiratory failure. However, do not follow this rule blindly. Always pay attention to your ABG findings as well as PaO2 and SpO2, because we could have an interstitial lung disease patient with, for example, mixed failure. Now, what types of underlying etiologies, as we discussed in our differential diagnosis episode for respiratory failure, are usually associated with pure hypoxemic failure and are not much associated with hypercapnia. Apart from conditions with hypoventilation and conditions associated with VQ mismatch, such as pulmonary embolism or left to right intracardiac shunts of acyanotic congenital heart diseases, or as we just discussed, conditions with impaired diffusion indices, these are usually pure hypoxemic respiratory failure. If you want to be on the safe side, always ask yourself these two questions. Am I dealing with a condition with impaired tidal volume or reduced respiratory rate, such as kyphoscoliosis, obesity, hypoventilation, or use of sedative hypnotics? Or am I dealing with a condition with impaired gas exchange indices, such as emphysema or lung fibrosis and pulmonary edema? Also, always pay attention to your ABG, and if you are provided any indices, you may be provided alveolo-arterial gradient. If it's increased, you definitely have the hypoxemia component. Next question. What type of hypoxemic respiratory failure may not benefit from oxygen supplementation? That's shunt. To conceptualize shunt, either think about the intracardiac left to right shunts or any condition that impairs gas exchange, because shunt simply means the unoxygenated blood is mixed with the oxygenated blood. And that's when the gas exchange is limited. So it could happen with collapse of the gas exchange architecture, that is alveolar collapse as seen in atelectasis, or buildup of fluid as seen in pulmonary edema and pneumonia, or conditions with alveolar hemorrhage as seen in, for example, Goodpasture syndrome or Wegener's granulomatosis. Also remember, in massive pulmonary embolism and conditions with total airway obstruction, oxygen supplementation would not be helpful. And as usual, remember, the mainstay for the treatment of almost all causes of hypoxemic respiratory failure is, as usual, addressing the underlying etiology. So based on that, let's review this case. You are the healthcare provider in a hospital in a high climax or mountainous region, and you receive an emergency call from some climbers who have contracted labored breathing. Upon arrival to the unit, you perform an ABG. The next question is, what do you expect to see in terms of AA gradient? Remember, in high altitude sickness, the AA gradient is normal, even though the patient do have hypoxia. What other management is important in addition to oxygen supplementation? Given the fact that the most common presentation in high altitude sickness is high altitude pulmonary edema due to hypoxic vasoconstriction, we treat the patient with acetazolamide to reduce the pulmonary edema. What's the other benefit of acetazolamide? Prevention of cerebral edema. True or false, patients with high altitude sickness could have mixed hypoxic and hypercapnic respiratory failure. That's absolutely false, because the patients with high altitude sickness usually are hyperventilating and they have metabolic alkalosis. Why among all diuretics we use acetazolamide is also related to the fact that acetazolamide does not induce metabolic alkalosis, while other diuretics, by activating renin-angiotensin-aldosterone system, would impose a secondary metabolic alkalosis by contraction mechanism, given the fact that alkalosis suppresses the respiratory drive. Now let's move to a couple scenarios in hypercapnic respiratory failure. Now if you are asked what is the best mode of ventilation support in acute exacerbation of COPD? What's the answer? The answer is BiPAP. On the other side, check this case. You have a patient with altered mental status and history of IV drug use. You evaluate the patient and figure out the patient does not have indication for intubation. True or false, BiPAP is the ideal mode for addressing this patient's respiratory needs. That's not necessarily the initial intervention because narcotic overdose could be managed by naloxone, and so we better use a method of ventilatory support with rapid reversal and ease of administration, and so we just use bagged valve mask. Again, remember the patient has a spontaneous breathing. Now, what medication should be avoided in any patient with hypercapnic respiratory failure? Sedatives. Why is it so? Because sedatives further suppress the respiratory drive and worsen the acidosis. Now, we discussed acetazolamide in high altitude illness. Now, if you are given a case of COPD and you are to pick the safest diuretic, what precautions are important? Again, remember typical diuretics induce contraction alkalosis. Alkalosis suppresses the respiratory drive. Why alkalosis can suppress respiratory drive? Because diuretic-induced alkalosis would require respiratory compensation by CO2 retention. Why acetazolamide is safe? Because acetazolamide induces metabolic acidosis that needs compensation by respiratory alkalosis, which is a stimulation of respiration that benefits patients with COPD. Likewise, as we discussed, what's the most important aspect of management for hypercapnic failure in a patient with opioid overdose? Naloxone plus providing means of rapid response to oxygenation, such as bag valve mask ventilation. Finally, remember, in patients with sedative hypnotic overdose, we don't resort to interventions like activated charcoal or gastric emptying. However, if all else fail and you need to reverse the benzodiazepine overdose by its antagonist flumazenil, what is the risk associated with this intervention? Risk of withdrawal seizure. One final case in this episode. If you are dealing with acute decompensated heart failure, what is the preferred mode of respiratory support? Remember, in acute decompensated heart failure, we are dealing with cardiogenic pulmonary edema and therefore a type of hypoxic or hypoxemic respiratory failure. We initiate the management with a non-invasive method. The choice between BiPAP and CPAP is BiPAP for hypercapnic type, such as acute exacerbation of COPD, but CPAP is the choice for acute decompensated heart failure. Remember, the PEEP that's delivered during the CPAP also help reduce the preload and improve patients' symptoms. This could function as a good transition to our next discussion, which is mechanical ventilation.